I want to welcome you to Persyst Grand Rounds, an online series of lectures hosted by Persyst, covering topics related to advanced EEG analysis for improving outcomes in both neurocritical care and epilepsy monitoring environments. My name is Marie Terrell, and I am the Director of Product Management with Persyst, and I'm here to introduce our speaker and our topic for today's Persyst Grand Rounds. So next slide, please. Yep, you're on it. Through our customers, we understand the importance of investing in the EEG community through education, where expertise and knowledge can grow towards the utilization and implementation of EEG and quantitative EEG. The goal of Persyst Grand Rounds is to provide a platform for those with clinical expertise on topics of advanced EEG analysis as a way to connect with a broader community to share their expertise and knowledge so that we can all learn and grow together. Each online lecture features an experienced epileptologist or neurophysiologist presenting on a topic of their choice as it relates to EEG monitoring and analysis. And you can visit our website, www.persyst.com/grandrounds to keep up to date with the schedule. And go ahead and hit the next slide. The opinions and viewpoints of each speaker are solely their own and do not represent Persyst or any other commercial entity or commercial interest. Speakers are not required to include Persyst, its software, products, or services. The content presented was not prepared or edited by Persyst. Persyst is not providing any form of compensation. And then finally, the last slide, the one that we have all been waiting for. Before I launch into the introduction, I do want to say that there will be time for questions after the talk. There is a little Q&A box at the bottom of your screen where you can write your questions, and we will address them afterwards. And we welcome as our speaker today, Dr. Ioannis Karakis, Professor of Neurology at Emory University School of Medicine. I'm going to read the bio first, Dr. Karakis' bio, and then I will read the title and the learning objectives, which are also there on the slide. So Dr. Ioannis Karakis is a professor of neurology at Emory University School of Medicine. He graduated with honors from the Medical School of Athens, Greece. Subsequently, he completed neurology residency at Boston Medical Center, Boston University, serving as the chief resident in the last year of his training. He then specialized in clinical neurophysiology by completing a 2-year fellowship with focus on EEG, epilepsy, and intraoperative monitoring at Massachusetts General Hospital, Harvard Medical School, and a 1-year fellowship with focus on EMG and neuromuscular medicine at Leahy Clinic, Tufts University, and Boston Children's Hospital, Harvard Medical School. He also completed a Master of Science in Epidemiology at the Harvard School of Public Health and a PhD thesis on quality of life in epilepsy in the Democritus University of Thrace, Alexandroupolis, Greece. I'm not sure I said that correctly. Dr. Karakis is board certified in neurology, clinical neurophysiology, neuromuscular medicine, and epilepsy by the American Board of Psychiatry and Neurology, in clinical neurophysiology with added competency in neurophysiologic intraoperative monitoring by the American Board of Clinical Neurophysiology, and in electromyography by the American Board of Electrodiagnostic Medicine. He has been elected as a fellow member of the American Academy of Neurology. The American Academy of Neurology, American Neurological Association, the American Clinical Neurophysiology Society, the American Epilepsy Society, and the American Association of Neuromuscular and Electrodiagnostic Medicine. He also serves at the Clinical Neurophysiology Examination Committee of the American Board of Psychiatry and Neurology. Dr. Karakis is interested in medical education and was conferred with the 2013 Faculty Teaching Award and 2014 Residence Friend Award by the Emory University Neurology Residency Program, the 2015 A.B. Baker Teacher Recognition Award by the American Academy of Neurology, the 2019 Hidden Gem Award by the Emory University School of Medicine, and the 2023 Distinction in Teaching Award by the American Clinical Neurophysiology Society. His research interests span the whole spectrum of clinical neurophysiology. So I have to say, we certainly have a qualified speaker here with us today. And so today, Dr. Karakis will speak on EEG in the intraoperative environment. The learning objectives will be to review the use of EEG in the intraoperative setting for various indications, including depths of anesthesia ascertainment, epileptogenic zone identification during electrocorticography, after discharges seizure detection during functional mapping, interhemispheric asymmetries recognition during cerebrovascular and cardiovascular surgeries. Number 2, understand patient selection, procedure planning and execution, risks and technical limitations, and anesthetic and systemic considerations, and results interpretation and reporting. And of course, the third objective to discuss future directions. So this is quite a lot. Dr. Karakis brings a lot to the table, and the topic is also quite interesting. This is the first time that we have had a speaker speak about EEG monitoring in the intraoperative environment. So I'm very excited about today's talk, and I want to thank you for being here. Dr. Karakis, please take it away.
Thank you very much for the kind introduction and the invitation. As mentioned, I'm going to talk to you about the EEG use in intraoperative setting. I don't have any pertinent disclosures to make. I just should say upfront that I have no financial relationships with Persyst per se, but I am going to include a couple of slides on Persyst applications with regards to the EEG use in the intraoperative monitoring that highlight teaching points and future directions, for the mere reasons that this is the software that I'm used to also from my own institution. Here's an outline of the talk. We will start with some introductory remarks, then move on the different indications for the use of EEG in the intraoperative setting with regards to monitoring the depth of anesthesia, monitoring for ischemia or electrocerebral silence, and then electrocorticography for monitoring for epileptiform activity or safeguarding functional mapping. We'll close with some concluding remarks at the end. As an introduction to the EEG, this is a modality that we use in the intraoperative setting from the early times, and we owe this to the gentleman illustrated here, Hans Berger, who in 1920s first described the alpha rhythm in the human brain, amongst which also his own son Klaus. Later on, there were other rhythms that were discovered, as you know, that are easily picked up with scalp EEG recordings with standard settings that fall within the Berger band, and outside the Berger band that we will mention later on in the course of this course. When we talk about EEG, essentially we talk about the amalgamate of extracellular inhibitory and excitatory postsynaptic potentials that are produced by the apical dendrites of neurons, predominantly the large ones, and those that are perpendicularly oriented to the recording electrodes. And because these signals are filtered by the scalp, at least with regards to the surface recordings, in order to pick up epileptiform activity, you need a substantial amount of cortex to hypersynchronize to be able to overcome that filtering. The settings that we use for recording EEG in the intraoperative setting is very similar to what we use for the outpatient setting or the epilepsy monitoring unit, at least with regards to the scalp recordings. We use either discs and caps, which are non-invasive. They have lower impedances, but it takes time to apply and they can be easily dislodged, or subdermal needles that they are more quickly applied and they allow for higher amplitude waveforms, but they are invasive and they have higher resistance and can be easily dislodged. The settings tend to be standard with the exception of bumping up the sensitivity to counteract for the effect of anesthesia and sometimes cramming a little bit the EEG sweep so that you can see the evolution of activity in a single screen. And of course, EEG machines used in the OR should have the same electrical safety requirements like every other machine with regards to patient contact, and the amplifiers should have the standardized settings to be able to be safe and efficacious. As far as montages are concerned, it is advisable to interchange between a bipolar montage as depicted on the top, where left over right is depicted between the two hemispheres, and the referential montage where each of the leads applied is referenced to a common reference, ideally one that is equidistant from these electrodes and it is not contaminated. The benefit of having the first montage is that it is the one that most people are used to, and that it gives you localization of activity by means of phase reversal. But if the field is quite large, it has the downside of phase cancellation, as opposed to the referential montages at the bottom that have the ability of localizing things based on the area of maximal negativity. And they, depending on where the reference is, they can provide useful information as long as it is away from the field of interest and has similar impedances, similar distance, and it's not contaminated in any way. With that in mind, let's move on to the different indications of EEG within the OR. The first and most common, used not only by neurologists but also by anesthesiologists, is to characterize the depth of anesthesia. As you know, the goal of the anesthesia is to provide unconsciousness, immobility, and control of autonomic responses to nociception. So the amount of anesthetics that is required is variable between individuals. There are people who are very sensitive, and for those utilizing standard doses may lead to prolonged operation, PACU stay, ICU stay, and subsequent complications, in addition to postoperative delirium, and theoretically also long-term neurocognitive decline. On the other hand, there are people who are resistant to anesthetics, and they are at risk of having increased awareness within the surgery, which is one of the most common litigation reasons for anesthesiologists. For that reason, utilizing an analysis of the depth of anesthesia with EEG would inform the anesthesiologist and the whole surgical team at the same time about the adequacy of anesthetics and counteract that problem. In a meta-analysis of 46 studies, it was shown that EEG-guided anesthesia decreased the anesthetic requirements, the emergence time, and expedited the discharge from the post-anesthetic care unit. Most anesthesiologists, they use only a couple of electrodes through which they record a bispectral analysis of the phase shift of the adjacent EEG waves, resulting in index. The most commonly used is the BIS index, the bispectral index, which ranges from 0, which means that the EEG is isoelectric, to 100, which means that the patient is awake, with a goal for an adequately anesthetized patient to be between 40 and 60. Here is how the EEG reacts to the different level of anesthetics. Initially, you get a high beta frequencies, which typically correspond to a BIS index of 70. As the anesthesia deepens, you start getting initially theta and subsequently delta frequencies on top of that. And with increased dosages of anesthetics, you start losing amplitude, and your EEG subsequently becomes isoelectric. A better example of that is depicted in this screen, where you see an EEG during induction with increased beta frequencies, later on with increased theta and delta frequencies, followed by burst suppression. And if the anesthetics would increase further, then you get totally isoelectric. You can imagine that all this can be depicted in parallel with other physiologic parameters to allow for a quick visualization of what's happening in the patient at the same time for clinical purposes, but also to facilitate research of how different anesthetics could be used and they can affect the brain individually. In this particular slide, you can see a quantitative analysis of the EEG in a compressed time range. After a bolus of phenobarbital, as depicted at the end, you can see that the spectral analysis changes quite a bit. The amplitude integrated EEG drops on both hemispheres with the addition of that anesthetic. And along the same lines, the heart rate, the respiratory rate, the intracranial pressure, they all get affected at the same time. So this type of multimodality monitoring in a compressed fashion in a single screen would be invaluable to the anesthesiologist for gauging the status of their patient. But you can imagine that for an intraoperative monitoring physician, adding to that slide the trends of changes that occur in the different evoked potentials that are being monitored, such as SSCPs or MEPs, would allow them to quickly understand how any changes that they see in these parameters are affected by anesthetics versus systemic factors that occur at the same time. So as a punchline with regards to anesthesia monitoring the brain is a no-brainer. Current evidence suggests that the EEG-guided anesthesia reduces the rate of awareness during TIVA and has similar efficacy in preventing awareness as compared with end-tidal anesthetic gas monitoring. There is insufficient evidence, however, to recommend the use of EEG monitoring for preventing postoperative delirium, neurocognitive disorder, or postoperative mortality. And multimodal monitoring, including EEG and other clinical neurophysiology modalities, along with systemic parameters, holds promise in intraoperative monitoring. Let's shift gears and talk about the use of EEG in the OR for ischemia monitoring. And the first indication that comes to mind with that is carotid endarterectomies, but you could apply the same technique for monitoring for ischemia in clipping of cerebral or aortic aneurysms, operations in resections of cerebral AV malformations, in bypass surgeries for Moya-Moya disease, even for procedures that take place in the endovascular suite. For example, with a selective WADA testing to identify which branches of an AV malformation are important to produce changes to the EEG signal to decide whether you can embolize them versus not prior to causing a neurological deficit. For carotid endarterectomies, which is the most common indication for ischemia monitoring in the OR with EEG, the rationale is that during the procedure, the carotid artery that is being operated, as well as the common carotid artery and the external carotid artery, need to be clamped. And that is a process that takes typically 30 to 45 minutes. And depending on the collateral circulation, it could cause ischemia, most of the time ipsilateral to the surgery, but occasionally also contralaterally. You can obviate the risk for a stroke due to that ischemia by trying to shunt the area that is being operated, but that is not always possible depending on the location of the plaque, and is not risk-free. A shunt can dislodge a plaque, can damage the wall of the vessel, or it can malfunction by itself. In fact, doing routine shunting in every single carotid endarterectomy is linked with higher stroke rate, approximately 2.5% compared to 1% when it is directed by EEG monitoring. And that's why we typically use EEG during carotid endarterectomies, either in isolation or in conjunction with other modalities. When it has been compared to other modalities, as for example, SSCPs, it has been found to be more sensitive to pick up changes. And that is also the case with other means of monitoring the risk for ischemia in that hemisphere, such as transcranial Dopplers or the stump pressure of the carotid stump or oxygenation of the brain. In my experience, there have been cases where EEG was more sensitive in picking up any changes, particularly during clamping. Other cases where SSCPs were more sensitive. So my take is as long as you can afford to utilize multiple means at the same time and try to combine modalities to be able to conclude. Bottom line is, though, that the monitoring can help reduce the risk of stroke by tenfold by helping the surgeon decide whether to selectively place a shunt or not. The reason that EEG is useful is depicted in this diagram, where you can see how much a drop in the cerebral blood flow affects the EEG waveforms. So as long as the cerebral blood flow is maintained above 35 mL per 100 grams of brain per minute, usually the EEG is normal and no major pathophysiological impact happens in the brain. But the more you drop the cerebral blood flow, and this is usually what happens in a patient during clamping, you end up seeing abnormalities, which initially are suggested by loss of fast frequencies, then increase in slow frequencies, initially theta, then delta, and subsequently loss of amplitude and complete attenuation of that hemisphere. So if a patient drops below 18 mLs per 100 grams per minute, then the risk for damage is substantial, especially if that change lasts more than 20 minutes. And if that drops further below 10, then that would be a threshold for infarction, in which case the surgeon needs to know that there is a high probability of postoperative stroke, and depending on where she or he is with regards to the operation, they can decide whether to wrap it up quickly and clean up the carotid and suture it back, or if they're in the beginning of the process and this is not going to be reversed anytime soon, put a shunt to be able to proceed with the surgery. The way we monitor raw EEG data during carotids is by splitting ideally the screen, where you put on the left-hand side the post-induction baseline and on the right-hand side the live record. This is a case that I monitored last Friday, where you can see how I'm aligning the different chains in an AP bipolar montage to be able to immediately compare what happens before and after the clamp and interpret whether there is any changing that occurs. The sensitivity has to be bumped up, and some people tend to compress their speed so that they can see the evolution better, but this makes interpretation a little bit more challenging if you are not used to these different settings. The anesthetic should be kept steady, because any boluses could affect the interpretation, particularly if these pertain to propofol, which can create a burst suppression discontinuous pattern that is very hard to monitor. The monitoring should take place ideally with multiple channels on each side, and it should last from the beginning of the surgery till the end of the surgery, because changes can happen at any time and not only during the clamp period. And the technician and IOM physician should document not only what happens to the EEG, but how that relates to changes in systemic factors like blood pressure, as well as the timing of the different stages of the procedure and the dosages of the anesthetics running concurrently. With regards to the interpretation, it has been observed that approximately 10 to 20% of cases show changes. These are not always severe, and frequently they are reversible with increase in the blood pressure without necessarily having to put a shunt. They most commonly occur in people who have poor contralateral carotid and posterior circulation, and in approximately 2% of patients, they are linked to poor outcome, especially if no corrective action is taken. The majority of the changes occur during clamping, and in the vast majority of the cases, that is in the first 1 minute and typically in the first 10 to 20 seconds after the clamp is placed. If they are severe and they last for more than 20 minutes, they will lead into irreversible damage. So what we use as alarm criteria for monitoring EEG in the OR is the loss of fast frequencies, or the emergence of slowing, or the drop in the amplitude, or typically a combination of all those three by more than 50%. And as I mentioned, the changes can occur at any point, for example, during exposure by manipulating the carotid bulb and causing bradyarrhythmias or thromboembolism, during clamping, during unclamping, in the process of back bleeding, or through thromboembolism, sudden changes in the blood pressure or anesthetics, and a phenomenon also of paradoxical arousal that could occur occasionally. Immediately post-operatively, when we typically stop monitoring by means of rethrombosis or hematoma, and 48 hours later by means of reperfusion in a previously deprived part of the brain from subsequent substantial blood flow that is now able to accept higher volumes of blood after the endarterectomy. This is an example of a left carotid endarterectomy. In the first few slides, you see the pre-clamp baseline. It is a AP bipolar left-right montage, and you can see a fairly symmetrical background that at some point when the clamp is applied, starts becoming slower halfway through that page on the left temporal more than parasagittal chain. You can perhaps appreciate that better in this next slide. These are sequential slides. And even here, the asymmetry is even bigger. You can see the loss of fast frequencies on the left, the drop in the amplitude, and the emergence of slowing. Thankfully, this case was able to continue with increasing the blood pressure, temporarily releasing the clamp, and trying again later without seeing these changes. So no shunt was required. On the contrary, the second case, which uses quantitative analysis, exemplifies how much more difficult things are when the record has low amplitude to begin with. Even if you bump it up to 5 microvolts per millimeter, which is how the raw data is depicted here on the right, it's a little bit difficult to see the fast frequencies, and therefore quantitative analysis can be indispensable, particularly in cases where you have a pre-existing slowing, and therefore it is difficult to ascertain what is slower than slow. So this is a case of a right carotid endarterectomy where, despite the symptomatic right carotid disease, there is no major asymmetry on the right hemisphere initially. Again, you have a left over right epibipolar montage. In this situation, the parasagittal chains are on the top and the temporal chains are at the bottom. And on the left-hand side, you see the quantitative analysis that depicts essentially 2 hours of recordings in one page. So initially, there is no huge asymmetry between the two hemispheres, but when the clamp is being placed, you can notice that the right hemisphere loses in amplitude and fast frequencies, but because it has already very low amplitude, and because it happens concurrently with some effect, although not as significant on the left hemisphere, it's a little bit more difficult to identify as opposed to the prior example that I showed you. So this is where the quantitative EEG could come in handy. I would draw your attention to the bottom 2 trends, where you actually compare the baseline frequencies of that hemisphere in the pre-last panel, the left hemisphere, in the bottom panel, the right hemisphere. So you compare the baseline frequencies of that hemisphere to what's happening at the time of the clamp, and the greener the color gets, that means that the more ischemia that hemisphere develops compared to its baseline by means of loss of amplitude and fast frequencies. So you can see that both hemispheres start becoming slower, although the right much more than the left, in line also with the raw EEG data, although these are a little bit attenuated and hard to observe. And as you move forward, about an hour post the clamp, in this particular case, that was not cold, so there was no intervention undertaken. You see that the same phenomenon exists and that accentuates. Now you can see that the right hemisphere is really more attenuated and with fewer fast frequencies compared to the left. The left still has some impairment. There is still some green into that panel, which compares that hemisphere with itself pre-clamp but post-induction. But as the anesthesia is lifted and the surgery is finished, the fast frequencies come through the left hemisphere pretty well. You can see them with the pink color at the end, but the ones on the right hemisphere do not return fully. Maybe you can appreciate that better in the raw data of the closing picture, where you can see that the right hemisphere is still slower as opposed to the left that has returned quite a bit back to its prior baseline. So using quantitative analysis in parallel with the split screen of raw EEG analysis can be invaluable in situations where the loss of amplitude globally is impairing reliable interpretation of the EEG data, or if you are not used to interpreting raw EEG, or you have a pre-existing slowing on one hemisphere and it's kind of difficult to evaluate additional changes. Having said that, quantitative EEG has a few seconds lag compared to raw EEG in its analysis, and it is fraught by environmental artifacts which are omnipresent in the OR. And for that reason, it should always be paired with analysis of the raw EEG data in parallel. Moving on to monitoring for electrocerebral silence, this is a procedure that is done predominantly for monitoring aortic surgeries, because those are performed through circulatory arrest to establish a bloodless field. And hypothermia during the circulatory arrest provides neuroprotection. So cooling the brain can reduce the metabolic demands of the brain and therefore the risk of injury. But if you overdo it, you may cause denaturing of brain proteins. If you underdo it, then you may not provide enough protection to the brain. So the EEG is used as a brain thermometer to determine the adequacy of hypothermia. The effect of cooling on EEG has been well studied since the early 21st century. In this particular study, you can see that with temperatures above 30 degrees Celsius, usually the EEG is continuous. When it drops below that, initially we start getting periodic discharges, which sometimes are generalized, sometimes they're lateralized to one hemisphere or both. And then when you go down to 24 degrees approximately, you start seeing a burst suppression pattern. And if you drop it further below 20 degrees, you start seeing electrocerebral inactivity, which is usually the target for deep hypothermia, although there are some studies nowadays that make an argument that even moderate hypothermia above that threshold could still be adequate to provide neuroprotection. Ideally, the EEG should be monitored with a double distance montage for the mere reason that this accentuates any amplitude and is allowing us to evaluate whether there is true global attenuation versus not. For the same reasons, using a higher a lower sensitivity, higher gain is allowing us to see whether there is still some residual brain activity or during rewarming, whether there are any focalities that suggest perhaps cardioembolism. Beware of the artifacts, because the lower the amplitude of the EEG, the more likely that external artifacts from electrodes malfunction or any devices that are used in the OR, or even physiological artifacts like EKG may start appearing into your screen. As far as interpretation is concerned, changes are seen in approximately 1/5 of the patients. And in those that they persist and they are not reversible, after rewarming, they are typically linked with increased chances of stroke and increased mortality. There is a significant inter-individual variability, and especially depending on the effect of anesthetics, because a cooled brain is more susceptible to anesthetics than a normothermic brain. And as mentioned before, there are different patterns of changes that you could see, and depending on whether they are expected or not from the cooling, there is an algorithm that is proposed by cardiothoracic surgeons that I'm showing you in the right side of the screen, where they typically increase the cerebral perfusion or evaluate their anastomosis with carotid ultrasound intraoperatively or with CT angiogram immediately post-operatively to see if there is any intervention that needs to be undertaken before it is too late. I'll show you an example of from our institution of how EEG interplays with the other evoked potentials during aortic aneurysm surgery. That was a descending aortic aneurysm, where you see on the top left-hand side the somatosensory evoked potentials from the upper extremities, left versus right, and from the lower extremities, left versus right. The red lines are the baseline, and the green lines are the current trial. In this particular page, I'm showing you the post-induction pre-exposure baseline. On the right top, you see the MEPs from the left side of the body, upper extremities and lower extremities, tibialis anterior and abductor hallucis, and from the right hemi body. And at the bottom, you see how the EEG looks like, which was pretty symmetric in the beginning, when there was no impairment in the evoked potentials whatsoever. Then during the exposure, the brain is being cooled. You can see that the EEG becomes burst suppressed, and inevitably your other potentials, the motor evoked potentials, start losing amplitude. Same thing happens a little bit also with the somatosensory evoked potentials, but they are still there and they're stacking up with their baselines, the red lines. So there is no major reason for concern. These are all anticipated temperature-related changes. But then when the patient goes on bypass and the graft is being placed, you can see that the EEG is expectedly isoelectric for neuroprotective purposes. but the motor evoked potentials from the lower extremities are totally lost. You only see them in the upper extremities bilaterally, as opposed to the somatosensory evoked potentials that they are still present in all four extremities, although they have lost some amplitude. You see the green waveforms that are a little bit lower in amplitude than the red ones, and they have shifted a little bit to the right, but the lower extremities, SSCPs, are much lower in amplitude and much more shifted to the right compared to the upper extremities that in this particular situation are used as a control because this is a descending aortic aneurysm. So that signifies that this is not just an anesthetic effect that we are seeing, which is partially the case, or a hypothermic effect, but it has to be related to spinal cord ischemia because it is asymmetrically affecting the lower extremities and first the MEPs rather than the SSCPs. So in that particular situation, we warned the surgeon about it. The surgeon took action to implant some of the feeding arteries to the graft that he was placing in the aorta so that the spinal cord gets reperfused. And thankfully at closing, where the EEG starts becoming a little bit more continuous with the rewarming, you can see that there is still a temperature and anesthetic effect by means of lower amplitude and right shifted SSCPs, even in the upper extremities that are used as a control. But the lower extremity SSCPs that we were concerned about are equally affected to the uppers, and the lower extremity MEPs that were previously lost have returned, albeit they are universally lower in amplitude compared to their baselines because there is still some discontinuity on the EEG. So this case exemplifies pretty much how EEG monitoring can help you guide the degree of impact from cooling and anesthetics and be able to differentiate whether that is purely a systemic effect that you are seeing in your evoked potentials, or there is superimposed through neurological changes and impending neurological deficit that the surgeon needs to act upon. I'm going to close with the use of EEG recordings directly from the brain surface, what we refer to as electrocorticography, both for the purposes of monitoring epileptiform activity and for the purposes of safeguarding functional mapping. We owe a lot of that to this gentleman on the top right-hand side, Wilder Penfield, who pioneered that with Dr. Jasper Dalby in the mid-20th century, using electrocorticography for assessing the background and the level of anesthesia, for monitoring epileptiform activity pre and post-resection, and for monitoring after discharges during brain stimulation. The intracranial EEG has quite a few differences compared to scalp EEG. The reason being that it records directly from the brain or in very close proximity to the brain from its surface, and therefore the generators of the signals are much closer and they are not filtered by the skull, which we know that attenuates signal considerably by 5-fold. Therefore, the signal that we get by monitoring intracranial EEG, either in the epilepsy monitoring unit or in the OR, they have higher amplitude and sharper contour unless you are recording from white matter with depth electrodes. And that becomes even more the case in the OR due to the effect of anesthesia, particularly in the pediatric population. Traditionally, we performed electrocorticography with subdural grids and strips that they had the luxury of providing better coverage of the cortical surface, although nowadays, especially in the epilepsy monitoring unit, but not uncommonly in the OR as well, we have pre-implanted stereo EEG electrodes that are used for electrocorticography that allow us to reach even deep parts of the brain with relatively low risk. When you interpret polarity through stereo EEG electrodes, you should remember that the polarity may vary depending on which contacts you are using, since the generator may have different orientation to these contacts, as opposed to monitoring from subdural grids or scalp electrodes, where there is a more standard orientation of the electrodes as compared to the generator. The beauty of intracranial EEG is that it is free, by and large, of artifacts visible on scalp recordings, although in the intraoperative setting with electrocorticography, that's not always the case because it's an electrically hostile environment. Therefore, you can have the ability, in addition to monitoring the physiologic activities, to, in a and to ask the patient to do certain functions if you are performing, let's say, the surgery under an awake craniotomy, and be able to record high frequencies and map passively local cortices. But in addition to monitoring for regular Berger range frequencies, you can also manipulate your settings and record infraslow activity and high frequency oscillations. We typically use both bipolar and referential montages, even for electrocorticography, which, as mentioned previously, have their own advantages and disadvantages. And differently from scalp recordings, we like to increase our sampling rate to at least 2000 and open up the high frequency filter to 500 Hertz to be able to capture high frequency activity as well. In order to perform proper electrocorticography, you need to know the case in terms of the clinical presentation, the prior EEG recordings, any imaging abnormalities, and how they are related to the area of irritability. You need to set specific goals for the procedure with the surgeon with regards to whether you are doing electrocorticography for identifying the epileptogenic zone versus its relationship to eloquent cortices, and how you are going to use these findings, or what are you going to do if the electrocorticography is uninformative. You need to communicate with the anesthesiologist with regards to sedation, because you don't want your EEG to be discontinuous or shut down because of high doses of propofol. And you need to prepare with your technician adequately to have the appropriate supplies for the lesion and craniotomy size. The technique has not really changed much. Essentially, you utilize strips or grids that could be custom made, that are placed on the exposed surface. Nowadays, also depths can be used, and you create a bipolar interreferential montage, which could be to the contralateral mastoid, to the flap, or even to inactive white matter contact if you are using depth electrodes. The settings are similar, with the exception of freeing up the high frequency filter occasionally for HFOs and bumping up the gain to 50 or 100 microvolts per millimeter, because everything looks inevitably sharper and of higher amplitude. As mentioned previously, artifacts can be omnipresent, and therefore it's important to ensure good contact of the electrodes with the brain surface by asking the surgeon to push them down, reposition them, or even irrigate. One common reason for poor recordings is when the tails of the electrodes do not attach well to the connector that brings them to the head box. So it's important to hear that snapping sound when they are given to you to make the connections. Ideally, like in every EEG recording, we should aim for low impedances and similar impedances, and be aware of the limitations of the bipolar and the referential montages that we already mentioned. As previously reported, propofol and barbiturates can suppress epileptiform activity, and that can be disadvantageous when you want to guide your resection by means of evaluating that activity, and they can also make your EEG discontinuous. So ideally, they should be used in very low doses, and gases should be used instead. Opioids and dexmedetomidine are okay. Same thing with neuromuscular blockade, unless motor mapping is planned. Occasionally, there is no activity that we can pick up epileptiform activity with the EEG. So utilizing some proconvulsant agents such as alfentanil, remifentanil, or methotrexate could help in that regard. The interpretation can be challenging when there are a lot of artifacts such as pulsation, EKG, or electrical artifacts, or there are a lot of normal variants such as mu rhythms, normal sleep architecture, or burst suppression, that they could be fooled as epileptiform activity in the inexperienced eye, particularly in children where things end up being even sharper than usual. In addition to epileptiform activity, we like to evaluate for background changes in terms of slowing attenuation. And these are some examples of that. So here you can see an example of epileptiform of EKG artifact that mimics epileptiform activity on the top left-hand corner. It is very monomorphic and time-locked to the EKG. On the top right, you see rhythmic activity in the Rolandic cortex, which may look sharp, but it's actually normal resting activity of the central motor area, the new rhythm, a burst suppression pattern at the bottom left-hand side, which may fool you as if it is epileptiform activity because of its sharp contour. And on the bottom right, you see an example of slowing when the strip is placed on top of the tumor, and faster frequencies coming into play when the strip is moved away from the tumor as part of monitoring for the background. But the main reason we do electrocorticography is to monitor for epileptiform activities. And this is exemplified by this case that I'm showing you here. So what you see here is a 42-year-old woman that we evaluated in our institution a few years ago, who was having intractable focal epilepsy with a hypermotoric semiology, suggested perhaps of a frontal localization, although she had an aura of fear and anxiety, suggested perhaps of an amygdala onset. So we ended up doing a pre-surgical workup during which we did not manage to find a LAT. So the MRI was normal, the scalp EEG was non-lateralizable, not localizable, and the PET did not have statistical significant lateralization either. So inevitably, we ended up doing something that is not advisable, which is a fishing expedition by implanting symmetrically electrodes in both frontal and temporal lobes, in the hope that we are going to at least lateralize her epilepsy and then add additional electrodes to be able to identify where the seizure focus is. We got lucky though, and we were able to see a very focal onset of her typical seizures from the right opercular area in this particular stereo EEG electrodes, and stimulating those electrodes in the epilepsy monitoring unit, both with low and high frequency stimulation, elicited the typical spontaneous seizures of the patient and the typical semiology for the patient. So what we ended up doing is we took the patient to the OR, and we planned for an operation, and like the one that you see in the red circle, and we conducted that along with electrocorticography. So interictally in the OR, we saw a lot of spikes that were repeating themselves. The same thing happens if you have an focal cortical dysplasia, which ended up being the culprit in this particular situation. And we were able to record also seizures from these opercular insular localization. And after the operation, we were able to find a very clean electrocorticography, which was very satisfying. And the patient is seizure-free ever since. So if you extend that to the literature and you try to see how useful electrocorticography is with regards to surgical outcome, I will draw your attention to the last column. You will see that there are half studies that say that it is correlated with surgical outcome, and the other half that state that it's not correlated with surgical outcome. And this actually creates a confusion as to what to believe. So why do we see such a controversy about the use of electrocorticography in epilepsy surgery? Well, one reason is that many of the studies that I showed you are heterogeneous. They are not randomized. They take mixed populations of children and adults, temporal and extratemporal cases, different methodologies of resecting that are not purely tailored to the electrocorticography, variable ways to ascertain what is interictal discharges versus not when interpreting the electrocorticography, and so forth. But the other reason is that occasionally when you operate on somebody's brain, the spikes that you see after the resection may not necessarily be the same spikes that you had prior to the resection in terms of their configuration and localization. And they may be just secondary to cortical isolation, surgical trauma, or activation of secondary foci. So in that regard, these spikes are green spikes, meaning you don't have to chase them, and they are not as important as the spikes that were habitual for the patient prior to the resection. And it also plays a big role whether you are referring to a surgery where you have a predefined plan of what you are going to resect. For example, if you have somebody with hippocampal sclerosis that has been tested preoperatively and is not functional anymore, and you know that you're going to remove the sclerotic hippocampus, then maybe changing the spikes may not portend to any substantial difference in the surgical outcome, as opposed to having somebody with the focal cortical dysplasia extratemporally, maybe close to eloquent cortex, and you need to identify which part of this big dysplasia is the epileptogenic zone and how does it relate to the eloquent cortex next to it. In that case, utilizing electrocorticography may make more conceptual sense. How about HFOs? For HFOs, there have been a couple of studies that came out in the last few years. The first one, which was retrospective, suggested that monitoring HFOs in the OR with electrocorticography is valuable, and that if you don't remove the fast ripples that you see before the resection, and they are still there after the resection, then that predicts poor surgical outcome. To their credit, the same group of investigators did a prospective study that was just published that tried to prove whether changing the HFOs is non-inferior to changing the spikes. So they randomized about 80 people to 40 in which they chased the HFOs and in 40 which they chased the spikes, the traditional interictal discharges. And they found out that electrocorticography is not non-inferior to spikes in terms of predicting surgical outcome. Therefore, it casts doubt whether chasing the HFOs in the OR portends to any significant benefit. So this is important information which would likely be investigated further down the road and try to provide us with a conclusive answer to whether HFOs can be used as a reliable biomarker versus not. One problem we have with monitoring HFOs in the OR is the fact that there is a lot of mechanical artifact from the hostile environment of the operating theater, and there is no good way to quantify them and track them down within the confines of a short intraoperative time. So thankfully, nowadays, there are endeavors to try to identify the HFOs quickly and reliably by just changing the filters of your EEG. This is intracranial data, not from the OR, but from the epilepsy monitoring unit, where you can see multiple seizures being recorded in the quantitative analysis on the right. And on the left, you can see the pre-ictal organization of the discharge, the spikes that lead to the seizure, that some of them, once you change the settings, you can clearly see the high frequency oscillations on top of them. So this allows us to track down and quantify the high frequency oscillations much quicker than we would normally do. And theoretically, it could be extrapolated in the OR within the time constraints of intraoperative electrocorticography. I will close with the use of electrocorticography to safeguard the accuracy of and the safety of functional mapping. We know that both in epilepsy and neuro-oncology, maximal resection of the area of interest is associated with better functional outcome. So preoperative localization of function, language function, motor function, you name it, is useful, but a lot of times it's suboptimal. Therefore, we frequently do extraoperative localization with neurophysiological techniques in the epilepsy monitoring unit by means of direct electrical stimulation or passive electrocorticography. But this is also limited to the positioning of the implanted electrodes and to the lack of direct anatomic visualization. Therefore, I think that intraoperative mapping and electrocorticography, as you are seeing in this video, where the surgeon is using a handheld stimulator and he's stimulating the brain at the same time recording electrocorticography through the strip, both with a bipolar and with a referential montage, is invaluable. The reason is that A, you want to make sure that you are not going to cause a seizure, and B, you want to make sure that the findings that you want to interpret, for example, positive language interruption or positive motor mapping, they are not because of the generation of after discharges, because if they are, they may be misleading you as to where the eloquent cortex is really located. But the main reason we do it is because we don't want to miss incipient seizure, we want to monitor for what we call after discharges before they organize into a clinical event. The video that I'm showing you here is purposefully chaotic to show you the mayhem that occurs during an intraoperative seizure during brain stimulation in the OR. So as you can see, the patient was being stimulated. The after discharges that were monitored with electrocorticography organized into a full-blown convulsive seizure, and the surgeon is now trying to pour copious amount of cold saline to the swollen bulging brain, and the anesthesiologist is trying to give boluses of anesthetics to try to stop this from becoming a bigger problem. You can imagine that if this is a patient who is getting an awake craniotomy, for example, the airway would be a problem, the increase in intracranial pressure would be a problem, the movement in a fixed skull on the pins would be a problem. So it is paramount to monitor electrocorticography and try to avoid this from culminating to a full-blown convulsion. And you do that by paying attention to after discharges, but I would argue that it would help also to pay attention to intrastimulation discharges. In other words, before you start seeing the after discharges, it's good to drop your notch filter on so that you can see what's happening during the stimulus artifact. We studied that a few years ago in the extraoperative setting, but the same principles apply intraoperatively too. Very frequently within the stimulation, you do see intrastimulation discharges that they localize at the same area with the after discharges, and they have the same exact risk to cause clinically evident seizures down the road if left untreated and unaddressed. And what I mean by unaddressed, meaning if you don't take any action to prevent them from happening again and organizing further. So when you see either intrastimulation discharges or after discharges on your electrocorticography, it is advisable that you drop down the stimulus intensity, you drop down the duration of the stimulation, and perhaps you go and stimulate another part of the brain before you go back to the area that was very irritable, hoping that it would help soothe things down in conjunction with cold saline before it culminates into a clinical convulsion. Last, I want to close with some future directions that are used currently in the epilepsy monitoring unit, but theoretically could be extrapolated also in the OR with electrocorticography. I briefly mentioned before that you can identify local cortex not only by stimulating the brain and trying to elicit interruption of brain function, language, motor, and so forth, but also by asking the patient to participate and do certain tasks, and then quantifying the high frequencies that are generated by the local part of the brain that produces these tasks. In this particular situation, you see a patient who is having a left frontal tumor, which is in close proximity to the Broca's area. And that was proven by extraoperative functional MRI. And what these investigators did is they utilized their grid that they placed in that region in the epilepsy monitoring unit and asked the patient to name some words, and they were quantifying the high frequency bands generated by these electrodes covering the Broca's area. And this way they were able to provide a colorful display of which part of the brain was controlling expression of language. You can imagine that within the time constraints of the OR, in an awake craniotomy, you could use a similar technique with electrocorticography to be able to passively map the brain function without necessarily having to undergo the risk of brain stimulation. It has promising results in the outpatient setting. It remains to be seen how well it can be applied in the intraoperative setting. So about electrocorticography, it is a well-established low-risk procedure that provides real-time information. It is essential for the safety and accuracy of functional cortical mapping, valuable for high epileptogenic neocortical lesions in proximity to local cortex, but equivocal for well-defined ictal onset zones such as mesial temporal sclerosis. As an epilogue, EEG is one of the oldest techniques used in intraoperative monitoring, and it remains an indispensable tool for monitoring the depth of anesthesia, ischemia, electrocerebral silence, and epileptiform activity, as well as safeguarding functional mapping. its successful application and interpretation, like every intraoperative clinical neurophysiology modality we use, depends on careful multidisciplinary planning and collaboration. And nowadays, newer equipment such as microelectrodes and newer signal analysis techniques such as automated computation and multimodality monitoring are reviving its utility. I'd like to thank Dr. Schauer and Michael Guest for providing some of the teaching examples that I showed you, and Marie for inviting me to deliver this talk, and thank you all for your attention.
Thank you very much, Dr. Karakis. That was an excellent talk. It was really our pleasure that you are here, and we're also getting a lot of thanks in the Q&A, so very much appreciated. So we'll just jump right in to the Q&A. And so the first one is a question from Lena Launen. For how long do you record electrocorticography during epilepsy surgery?
Yeah, that's a good question. It really depends on multiple factors. So you definitely want to get a baseline post-induction pre-resection and one during and after resection. Whether you're going to continue to record further depends a lot on what you're trying to achieve. So in conjunction with the surgeon, if the goal of the surgery was to identify the epileptogenic zone and you were able to get a lot of epileptiform activity interictally or ictally already, and you have that answer and you have resected and it went away, you can pretty much stop. But if that has not been achieved yet, or if you want to continue to record electrocorticography for the purposes of identifying after discharges in the context of stimulation mapping, then the length of the procedure will have to be extended. And of course, it depends on whether you are able to do it, meaning the size of the craniotomy allows you, and the surgeon has time to dedicate, and the anesthesiologist is working with you not to suppress the EEG, so you can still make something of the results.
Wonderful. Thank you. Okay, next question takes us back to the cooling. Do you monitor TAAs through the cooling period?
Yes, we monitor, we continue to monitor throughout the case because we want to make sure that the patient doesn't become, for example, less hypothermic or less suppressed during the time of the grafting. And then during the grafting, we want to make sure that for the rewarming period, there is no focality that emerges that would signify perhaps some cardioembolism. Also, rewarming the patient very quickly can be problematic because it creates a hypermetabolic state of the brain. So you want to monitor throughout the cooling to make sure that the transition from a flat EEG to theoretically a normal symmetric anesthetic pattern subsequently is indeed achieved at the appropriate pace.
Wonderful. Okay. And then regarding depth of anesthesia monitoring, there's a couple questions about this. One is, which type of anesthesia do you recommend? Actually, this is for electrocorticography. Sevoflurane, isoflurane, or TIVA propofol?
Yeah, for electrocorticography, you typically do it to be able to evaluate the extent of epileptiform activity. So if you use barbiturates or propofol, you are going to shut the brain down and you won't be able to achieve that. So ideally, you should be using, you should be inclined to use more the inhalational agents or other agents like opioids or dexmedetomidine that would not really abort any interictal epileptiform activity. Obviously, if you have a seizure that is generated spontaneously that has visible convulsions or during mapping, then you may resort to boluses of barbiturates or propofol to abort it, but that is the worst case scenario you are trying to avoid.
Okay, okay, great. And then along the lines of the electrocorticography recordings as well, there's some questions on what are the stimulation parameters used in mapping motor or language cortex?
Yeah, that's a whole topic by itself.
Yeah, indeed.
Yeah, just in a nutshell, because we're running out of time for motor mapping, we use the multiple strain technique, which could be done either with a handheld stimulator or through the strip that you are using for after discharges. You can add a second strip and stimulate through the strip and leave it in place to monitor the pyramidal tracts when you are resecting next to it. So it's the same essentially principles of motor evoke potentials transcranially, but with obviously a much lower stimulus intensity. For language function, we still use a traditional penfield technique of 60 Hz stimulation, and it's usually cathodal as opposed to anodal for motor mapping.
Okay, great. So we are running out of time. I do want to propose one last question. Can you talk a bit about depth of anesthesia via EEG versus BIS?
Yes, so the anesthesiologists do not have the luxury of learning a lot of EEG during their training because there are so many other things that they need to learn. So inevitably, they resort to automated methods like the BIS algorithm, which, as I mentioned, is better than nothing, but is not always reliable. It can sometimes be fraught by artifacts that creates frequencies that are not cerebral, or it cannot really interpret phenomena like paradoxical arousals that could occur occasionally and may mislead your level of anesthesia if you are counting only on the BIS index. So ideally, you should have raw EEG data, and if you don't have the luxury of applying a full headset the way you would normally do for monitoring for carotid endarterectomies or a double distance montage the way you would do for monitoring for electrocerebral silence, at the least, you can utilize your C3, C4 electrodes that you have there in intraoperative monitoring for your SSCPs, and you can monitor raw EEG through those two channels. So it would be nice to combine it with the BIS at the same time.
Got it. Okay, fantastic. So we do have quite a lot of questions that we haven't gotten to yet, and they're all coming in now, which is great. I'd love to see the interest. What we can do is answer your questions afterward in the follow-up emails that we will send with a link to this recording. So Dr. Karakis, if we send some of these questions to you, could you assist us in answering them?
Yeah, definitely. I think I'm still sharing my screen, so you can see my email address. By all means, feel free to email me, and I would be happy to answer any questions you have.
Fantastic. Thank you so much. This was a very interesting talk, and I feel that each of your categories could be a talk in and of itself. So really appreciate your time, and thank you very much.
Thank you for the invitation. Thank you all for joining.
Thank you.
Bye-bye.
Bye.